Welcome to podcast 16.
I'm Fran.
And I'm Minnie.
And as usual, please do feedback on the podcast. Any constructive criticism is very welcome, as are ideas for future podcasts.
Thanks, Fran. So today's podcast, we're going to talk about neonatal jaundice. And this we're going to break up into probably two parts, possibly three, because it's quite a complex subject. So this is part one. And the tip is, please consider risk factors for jaundice in the neonatal period.
Brilliant. Thanks, Minnie. So as Minnie said, we're talking about neonatal jaundice today. And the first thing we're going to do is refresh ourselves on the definitions, do a brief review of bilirubin metabolism, and then the consequences and the risk factors for developing hyperbilirubinemia. Way, I managed to say it.
Brilliant. Okay. So what is neonatal jaundice? It's good to get these definitions sorted. So it is a form of jaundice, which is a yellow discoloration of the skin caused by the deposition of bilirubin. And as it's neonatal jaundice, it's obviously jaundice in the neonate, and a neonate refers to a newborn up to the age of 28 days. And as Fran has just told us, raised levels of bilirubin causing jaundice are known as hyperbilirubinemia.
So Minnie, why are we talking about neonatal jaundice today?
Okay, well, I thought it was a good topic to choose because it's a common problem worldwide. It can affect up to 60% of term infants and 80% of preterm neonates. So it's pretty common. And in the majority of cases, the jaundice is physiological. It resolves without intervention. So physiological jaundice usually presents between 2 and 3 days of age and disappears at the end of the first week and is usually completely resolved by 10 days. When you measure the bilirubin level, it doesn't exceed 200 micromoles per litre of bilirubin, and the baby remains well throughout. Okay, and about 10% of breastfed babies, however, are still jaundiced at a month of age, but it's not a level that you are concerned about.
Okay, so in contrast, there are some neonates that develop this high level of jaundice, and that can result in irreversible and permanent brain damage if it is not treated. So the resulting problems include deafness, kernicterus, which is an acute bilirubin encephalopathy, and athetoid cerebral palsy. So Minnie, you were saying that you had a patient who had athetoid cerebral palsy following hyperbilirubinemia as a neonate.
That's right. So I met her when she was 9, and she was quite a regular inpatient with her having had kernicterus as a baby and was left with the cerebral palsy. And athetoid cerebral palsy is you have many movement problems with your arms and legs, so it's very difficult to be still. And she had quite a lot of problems with communication as well, but she was very bright actually.
Bless her.
Yeah. So
it's a horrible thing that is preventable. That's the thing.
Right.
So, yeah. And just remember, so the bilirubin level at which this encephalopathy will happen, the level is lower in preterm babies.
That's right. So the damage occurs at a much lower level. That's right. So thankfully, the incidence of severe hyperbilirubinemia is much less common than neonatal jaundice per se. So only around 2% of term infants will have a severe jaundice. When I was looking in the BMJ, and I found a systematic review and meta-analysis that they carried out last year that was looking at the burden of severe neonatal jaundice worldwide. And worryingly, they found that the African region has the highest incidence of severe neonatal jaundice per 10,000 live births globally. So that's 667 infants per 10,000 live births.
Gosh.
So just to clarify when we're saying severe neonatal jaundice, they defined this as a clinical outcome. So the definition is of the clinical outcome of acute bilirubin encephalopathy, which, as we've said, is kernicterus, and whether the baby needed an exchange transfusion or whether the baby died and it was a jaundice-related death. So that's how they quantified those babies.
Okay, so this is really relevant to you guys out there in Zambia, to recognise when this is a problem and to, actively treat, refer, whatever.
Yeah, are you still there?
What is hyperbilirubinemia?
I've just completely lost you then, Fran.
Oh, I'm back again. We were just going to talk about what is hyperbilirubinemia. So I was going to say that in neonates, the bilirubin levels are higher than in adults because they have a higher concentration of red blood cells, and each cell has a shorter lifespan. So when the red blood cell breaks down, it creates unconjugated bilirubin, and that circulates around the body, mostly bound to albumin, which is a protein in the bloodstream. And from here it travels to the liver, where it's metabolized, and that produces conjugated bilirubin, which is excreted in the stool.
That's right. However, Fran, babies also have a process called enterohepatic circulation of bilirubin. So this is where an enzyme in the intestine converts some of the conjugated bilirubin back into the unconjugated form, so that it is then reabsorbed and recycled in the circulation.
Okay.
So this makes the level of conjugated bilirubin in the baby's bloodstream very low and the unconjugated bilirubin very high in comparison.
And Minnie, is it right that breastfed babies have more of this circulation than non-breastfed babies, which is why they're much more likely to have the physiological jaundice?
That's right. So they have breast milk, for some reason, increases the enterohepatic circulation. Okay. And yeah, that gives you breast milk jaundice. So it's not that you're lacking milk, but it's just that the milk itself is causing the jaundice by this method of recirculation.
Okay, and so how do we measure the level of bilirubin based on the child's age?
So we take a blood test, usually a heel prick.
Okay.
And you can measure the bilirubin from that. So you're measuring the total bilirubin, and then if you often need to do some other tests as well to see how much of it is conjugated and unconjugated. But we'll discuss that further in the next podcast, Fran, when we're talking about the different types of jaundice. Okay,
and then with those levels, You mentioned there's a special graph.
Oh, okay. Sorry, is that what you were wanting me to say? So, okay, right.
Both things were useful.
Yeah. So the hyperbilirubinemia has a more specific definition. So in each baby, this is based on a type of special normogram graph, which is standardized bilirubin levels in relation to the neonate's gestational age and hours of life. So every baby needs a different graph. So you'll have a graph for a 36-week baby, and along the bottom is the time of how old they are in hours.
Okay.
And this helps to guide treatment, so that on that chart there is a level at which you need to start treating the jaundice. And I've attached at the bottom of the transcript just an example of one of these normograms, and I'll see if you're interested. I'll see if I can get hold of the software so that you can see them all from. You can just type in the gestational age and then get the relevant graph, because that's certainly what they use in hospitals here now, rather than having to find a sheet of paper.
Brilliant. So guys, let us know if that would be helpful to you. So hyperbilirubinemia can be considered severe when the onset of jaundice is within the first 24 hours of life,
mm-hmm.
when the rate of increase in total bilirubin is too high. Thirdly, when the level of conjugated bilirubin is too high compared with the total. Or finally, when the neonate has signs and symptoms of a serious illness. So we're not just treating the numbers, we're looking at the baby as well.
That's right. And the other thing I would just like to mention about the level and these graphs is that the hyperbilirubinemia is defined as serum bilirubin greater than 95%, the 95 percentile on the neonate's normogram. So that's where treatment starts, at the 95th percentile. So there is a variation in what is acceptable, but the
Brilliant.
graph is really helpful in pinpointing when to start treatment.
Okay, fantastic. So why are we treating it?
So we need to treat it because when there's too much bilirubin in the infant's blood, it overwhelms the albumin binding capacity, and so the albumin isn't transported to the liver and excreted. So the bilirubin builds up and then it is free to cross the blood-brain barrier. Now, bilirubin is neurotoxic, and high levels result in bilirubin-induced neurological dysfunction, as we've described before with connectorus. It does produce a spectrum of neurological findings, Fran. And some of them are quite subtle and some are severe, as we've already mentioned. And this is related to the level of the bilirubin and also for the length of that elevation.
Okay.
So acute bilirubin encephalopathy is actually a clinical syndrome. And what you will see is at first the baby may be a bit floppy, be more sleepy than normal and have a poor suck. So, a mother might say to you, maybe even within the first 24 hours of life, my baby's not feeding, I can't wake it, or him or her. But then as the bilirubin increases, the infant can then develop a high-pitched cry, can be difficult to console, become febrile and hypertonic, so stiff.
Okay.
As it progresses, the baby develops apneas, so that's episodes of stopping breathing, is unable to feed, and then there are a couple of specific postures of severe muscle contraction, so a persistent retrocollis, which is where the neck is tilted backwards, and opisthotonus, which is an abnormal arching of the back with the head tilting as well. So they're quite abnormal postures to see in a newborn infant.
Right.
They may also develop seizures, coma, and it can even, as we've mentioned, lead to death. Now, if you catch it early, it is reversible. So it's important to recognise. But otherwise, it can lead to the longer standing problems of connectorus, which we've already mentioned with the cerebral palsies and movement disorders and
yeah. And many, so obviously these are clinical things we're looking at, but when we're looking at the baby, they are obviously jaundiced.
Okay, so this can be difficult to see in dark skin. Because, in a Caucasian baby, you can often see yellowing just of the skin, but you need to look carefully at the
conjunctiva.
That's right. Look at the whites of the eyes. That's where you will really see if there's any jaundice. Palms of the hands, soles of the feet. Those are the areas to make sure that you do look at to see.
Okay.
Because you don't want to miss. Once you're starting to get yellowing of the eyes, then that's a significant level, really.
Yep. Absolutely. So moving on, so Minnie mentioned that this encephalopathy can lead to connectorus, and this occurs when the bilirubin is deposited in the brain and it causes staining of the brain, and it causes necrosis, which is cell death. Right. And it often affects the basal ganglia and the brain stem, and most of the effects are then coming from the resultant damage to these areas. So as we mentioned, this includes cerebral palsy, hearing loss, gaze abnormalities, some dental dysplasia, and developmental and learning delays and difficulties.
That's right. Okay. So that's the sort of definitions, really, of the first part that we want to do on neonatal jaundice. But we also said we'd mention the risk factors. So there are risk factors for developing significant neonatal jaundice. So there's a bit of a list here. So first, low birth weight, so whether you're premature or whether you're small for your gestational age. Mm-hmm. Breastfed babies, as we've mentioned, and we'll go into that in a little more detail in the next podcast.
Brilliant.
A previous sibling with neonatal jaundice that has required phototherapy or other treatment. As Fran mentioned, visible jaundice within the first 24 hours. That's something you must look out for. Infants of diabetic mothers, Asian ethnicity, blood group incompatibility, so that's ABO or rhesus incompatibility, because this leads to hemolytic jaundice. Birth trauma, so any bruising, that's going to increase your number of red blood cells that are being destroyed.
Absolutely,
Instrumental deliveries obviously can increase that, or just
Von twos with that big cephalohematoma, isn't it? Yeah.
And finally, torch infections, which are
toxoplasmosis, other rubella, CMV, and herpes and HIV.
HIV, that's it. And there are other infections which are now part of torch that you need to think about as well. So in summary, jaundice, also known as hyperbilirubinemia, is common, and it affects over half of term babies and nearly all premature neonates. Severe hyperbilirubinemia must be treated in order to prevent bilirubin-induced neurological dysfunction, with the long-term consequence of kernicterus. Plot bilirubin levels so that you know the degree of hyperbilirubinemia, and to determine whether treatment is needed, or whether you need to refer a child to a place where they can receive treatment.
Fantastic. Yeah. So this is really helpful. In fact, I have to confess, Minnie, I'd forgotten a lot of this. This was really helpful in just reminding me. No, because it's such a, I qualified 20 years.
Do you?
I don't use it every day. I qualified 20 years ago. So it's good to understand what the risk factors are, why this might be happening, and just be alert. If the child looks a bit yellow and there are risk factors there, you need to be investigating this. As we mentioned, so this is only the first part. So in the next part, we're going to discuss the difference between physiological and pathological jaundice, and discuss a clinical approach to neonatal jaundice and what your treatment options are. So keep listening.
Thanks very much.
Thanks, guys. Take care. Bye.
Bye.